I'm Chip Routt from here at the University of Texas Health McGovern Medical School in Houston, Texas. I work at Memorial Hermann Hospital, and these are my disclosures. Tonight, of course, we'll be discussing the CurvaFix. I work here in the Texas Medical Center. It's a pretty vast area, and our hospital's that one over there on the lower left, the orange roof buildings, and just right next to us is another level 1 trauma center. Here we serve 7 million people in the metro Houston area. This is a team that I work with, a really dedicated group of people. As you know, it takes a huge village to provide high quality trauma care to a large metro area. And this is a group that really does a lot of hard work. So I'm really grateful to be a part of this team. We'll talk in this session mostly about just the problems. This is one of my recent patients, and I think you can understand one of the problems we'll probably touch on already just by trying to see the bone in this radiograph is pelvic injuries in senior patients. We're going to just really focus in my session on the problems and the issues and stick to about 4 of them. And then I think you'll find the other people that are following behind are going to deal with the solutions to it. But I'd like to just highlight some of the problems that I think most of you may be aware of, but we'll certainly get into it. Probably the first thing to think about is just the host and the overall situation. Senior patients have a real spectrum of functionality, and their ability and their agility and their activity. I think all of y'all are very aware of the real wide range of this and how we have to adjust and treat our patients accordingly. These aren't young, usually high energy traumatic events. These are usually people that are in some form of constrained living environment. They may or may not have the ability and the agility and the mobility that we all seek. And so it really is important to understand the host and their support system and the safety nets that they have, as well as just other issues. I just want to look at this picture. This picture is of 2 of my mother's very good friends. One, you can see broke her pelvis and had a surgery and has been doing quite well. The other broke her pelvis and had an unstable pelvis, but was told she didn't need a surgery. She's been in a chair for about 6 months at this point. She wasn't getting better. And I'll just tell you, for the last 8 years, she's been stuck in the chair without a good quality lifestyle. So fixing and stabilizing unstable pelvic ring injuries, I would say, is pretty critical and borne out just by the tale of these two individuals. But they all come with medical comorbidities of some variety, hypertension, diabetes, you know all of these things. And I think the things that tend to steer us or really make surgeons sort of wander away is not just the bone quality or the host issues, but sometimes the prior surgeries, the scarring, the hernias that they might have. Like this is a pretty massive hernia, and you can see the anticoagulation that this patient is on for his other conditions has really caused him to have at least some ecchymosis problems. So all of these things go into complicating the host. We talked a little bit about the bimodal distribution of pelvic ring and pelvic injuries in people. These are usually now low energy falls and things like that. These are typically low drama events. You know, young people have these high drama events where they wrecked their motorcycle and they were found 200 yards away and they flew through the air and all these things. But typically elders are just tough people. Sometimes they're impaired with their communication abilities for other things in life, just of living the privilege of living a long time. And then we have the bone quality issues that we talked about. So I would just say it's really important to make sure we have an awareness that pelvic ring injuries and other types of pelvic fractures can occur in these patients, and they can be unstable. Probably awareness of instability or awareness of these injuries is one of the problems that we face in today's world. I'm also just going to highlight, I think, the 2 types of fractures that these patients tend to get. The one that you're probably most familiar with is just the pelvic ring injury. And almost all of these, luckily for these patients, are typically stable fracture patterns, but we have to make sure that they are stable. And the easiest way to do that is to just do a physical examination to assess ring instability. Typically, these patients with ring instability will be very much more symptomatic than usual. They won't be able to find comfort. They may not even want to talk to you. They don't want to roll. They don't want to breathe. and the imaging may or may not be reassuring to us. We tend to see a lot of physicians that will say, well, I think it must be stable because I don't want to operate on it. But it would be smart to just examine it and do a compression exam. And you can see just by a little bit of compression on the pelvis, you'll be able to reveal instability. If you don't have a good sense of this with your physical exam, you can also just apply a binder or apply a pelvic circumferential sheet, and you'll be able to see the revealing of the instability, a fairly simple thing to do. So making the diagnosis is crucial to helping the patients get on the right track from a treatment standpoint. The other thing is if the radiographs really aren't satisfying to you, you can use volume rendered images from the CT scan like this one. This patient, it was pretty hard to see her fractures until we used the volume rendered imaging. The volume rendered imaging was very revealing for seeing this. And then of course, we can supplement it with the surface rendered images that give us a little bit better idea. I think it's interesting when you look at the surface rendered images to understand what you're seeing. Look at the right-sided sacral ala on this patient. Her bone quality is so poor in her right ala that the computer software program has rubbed it out and just exposed it as cancellous bone. So we have to be a little bit careful of what we're looking at when these computer programs give us this information so that we know exactly what we're seeing, and we have to correlate with the volume rendered images and the surface rendered images, and then also the axial images. The axial images, if you look at this lady's axial image, you'll be able to see why the software package thought that that ala on the right side wasn't there, is because her cortical bone of her anterior ala on her right side is really less dense than her left side, the injured side. You can also see her iliac fracture, the sacroiliac disruption, and you can even see her sacral crush on the left side as well, the displacement of the sacral side as well. So the CT axial images, the coronals and sagittals all give us further specific details of the injury to help us plan, just like we should for young adults, but even more sensitive for the elders as a result of their bone quality. You can also see at the second sacral level, the morphology of the sacrum at that site, so we can have a really accurate plan if we plan to reduce and stabilize this. And then you can see the density of the parasymphyseal bone. A lot of these patients will have different conditions. You can also see how her acetabulum relates to her femoral neck, things like that, or body habitus. All types of details come with the axial CTs, as you know. So that would be pelvic ring injuries where you have two areas involved and you have instability that is typical for ring instability or not. And then probably the one that's the most missed fracture, or the ones that at least I see over the course of my career that come to me as delayed diagnosis, or patients with bilateral sacral fractures with U, H, Y, and backwards Y patterns. These don't often involve the ring unless it's a Y or backwards Y or H, but the U patterns spare the ring. The patients have usually fallen. They're complaining of low back pain. The radiographs may or may not be apparent to the physicians. CT scans are usually not obtained, and the diagnosis is missed until there's some type of displacement or deformity that causes the patient to have the inability to mobilize, or they start having bowel and bladder symptoms as a result of the kyphotic displacement of the upper sacrum into the canal. So it would be great to improve the awareness of this throughout our professional colleagues. And if nothing else, we could just alert them to the paradoxical inlet, where we see an inlet appearance of the upper sacrum as a result of the kyphotic displacement of the bilateral sacral fracture with a transverse limb, the so-called U-shaped sacral fracture. The AP image is directed normally, and so the rest of the pelvis looks like an AP, but as a result of the displacement of the upper sacrum due to the fracture there, we get a kyphotic displacement, and so the posterior ring looks like an inlet and the rest of the ring looks like an AP. A really good thing to teach your emergency room colleagues or people that are screening patients, family medicine doctors, et cetera. Really important thing for them to see, because it's kind of hard sometimes, even if you get a fairly good true lateral view, to see it. But again, if you do get outlet imaging, a lot of times you can see the essentially intussusception of the spine and the upper sacrum onto the sacrum itself. Again, just radiographic findings that may or may not be obvious as a result of the osteopenia or osteoporosis or bone quality issues. But again, you can understand why a lot of these get delayed in diagnosis. Nevertheless, we use the axial images to sort out the details. You can understand why some of these come with neurology and they present with neurological findings like this patient's did. And then you can see we have a third problem, which is just people trying to help and do things that they may or may not know how to do. And so a lot of devices have been created, but they don't really address the problem. And then a lot of times people don't understand what they're doing. And you can see here, when we don't put implants into the bone, it really doesn't work very well. So regardless of what we use, whether it's screw or CurvaFix or other devices, we have to put them in the bone. Another problem with treatment is our colleagues are trying to help. And if you know how to just squirt bone cement into bone and it worked for the spine, then maybe it'll work for the sacrum, but it really doesn't. And so if you have colleagues that are smearing bone glue onto the surface of the pubic ramus percutaneously, or they're cramming it into the ala and putting it in there, this is really not going to help the patient. And then we're going to have trouble. I can't really get an implant through this bone cement. So I would, if you have colleagues doing this and then they expect you to bail them out, you might want to have some conversations about that and avoid that. But I think this is a real, I think the diagnostic problem, the citing or identifying the instability or identifying the U-shaped fractures is one thing, but this is even worse. So the treatment problems bleed over into us as well. So if we can identify the injury, we can identify its instability, and we can get ourselves to that point, now we have to deal with reduction, and we have to deal with fixation, and we have to deal with the imaging of this poor bone quality, and then the implants that we would use to sort it out. So the planning becomes really, I think planning is always very important, but the planning gets incredibly important with this. Typically, we just have standard straight implants up until now. With the CurvaFix, we have rounded or curved implants that can accommodate these curved pathways. But up until now, we've just been stuck with straight, trying to put straight implants into curved structures of bone, which in some situations may work, but in some situations may not work so well. So you can see we can solve the problem for people with their ring injuries. We can address the sites of instability, and we can put these devices in that may or may not be sufficient for what we're doing. And we can verify post-operatively that we have safe screws well located where we wanted them to be. But then we have a fourth problem, which is hanging on to what we've got. And we see that even when we think we've got things in pretty good shape, we have fixation failures. So with that, I think we'll get started with our next group of speakers. But before we transition to them, I just want to leave you with these 4 problems. I promised you 4 problems, and I've actually snuck a few others in. I want to make sure you remember the host issues. We have a spectrum of hosts, and they have a lot of issues, but the thing that we're trying to deal with the CurvaFix is just the bone quality and the bone morphology. We don't want to forget when we're taking care of these patients that once we do get them fixed, we want to make sure that we make sure they get on the proper medications and the diet and the supplements that they may or may not be on at the time and what have caused their problems. So we don't want to forget about our bone health clinics. We want to help with the improving the diagnostic ability of our peers so that these patients don't get missed. And that's education, that's physical exam, that's increasing awareness. And then again, our own clinical aggression. So many times you get busy and things sort of take over, and it's just another someone that fell down, and you don't think it's too much. But I would implore you to be aggressive with your clinical seeking disease and not hoping for wellness. Typically, it's best to do a full workup and make sure you haven't missed something so that these patients, especially the U patterns, don't progress on to cauda equina symptoms. And again, sort out the ring injuries if they're stable or unstable. Just because they fell doesn't mean they're not unstable. It's always great just to rule out instability, and you can move on with closed management, or identify instability so you can move on with stable early treatment. And then again, the bilateral sacral should be the herald of the U pattern or the Y pattern, the H pattern, and you can learn more about that as we go. And then with the management, the imaging is so important. It's really important to get the accurate reduction and stable fixation. And what we're here to learn about tonight is the precision that's demanded for these patients, and these the new implant that we'll be talking about tonight, that gives us the ability to treat these patients and to make sure that their conduits of bone that demand the stability can get the implant that they need for that.